Dear colleagues and friends, welcome to this webinar. My name is Pascal-André Vendittoli. I'm an orthopedic surgeon working at Hôpital Maisonneuve-Rosemont in Montreal, Canada, and full professor of surgery at University of Montreal. I'm one of the founders of the Personalized Arthroplasty Society, and today the topic will be mechanical alignment total knee arthroplasty. Is it the end of an era? So with mechanical alignment total knee arthroplasty, did we achieve success? In fact, not really. 75% of our patients do not experience a natural joint. 50% of them have residual symptoms. So we should question ourselves, how can we improve our results? We know that the key factor for total knee arthroplasty success is to restore normal knee kinematic. The knee kinematic are linked to the geometry of the articular surfaces and the functional axis of the knee joint. It also relies on the soft tissue tension and laxities. Let's start with knee geometries, effect on ligament tension. We know that normal knee from 10 degree to 120 degree of the arc of motion, the MCL and LCL are almost isometric. But the ligament tension is a bit more complex. From the work of Pinskerova, we know that in the medial compartment, when we go in full extension, so between 0 and 10 degrees, the medial condyle jump onto an anterior facet, which put the MCL into maximum tension. That's why we can lock the knee in full extension. When the knee flex above 120 degrees on the medial compartment, the femoral condyles start to move posteriorly to a limited amount. This allows full flexion above 120 degrees, and as you can see here, the meniscus on the medial side is compressed against the femoral condyle in full flexion. In the lateral compartment, this is slightly different. The lateral femoral condyles stay centered until 45 degrees of flexion, and beyond 45 degrees start translating posteriorly. So in fact, the collateral ligaments are not isometric during the arc of motion. And the key point to remember is that there is a high individual variability in the ligament tension. Women are more lax than men. MCL is tighter than LCL, and the MCL and LCL become looser with more flexion. This results in a very specific knee kinematic between the femur and tibia. As you can see here on the medial side, the femoral condyles stay almost centered toward the arc of motion. And on the lateral side, there is a very important translation where you see at the end of flexion, the lateral meniscus is almost subluxed posteriorly. This was described by Freeman and Pinskerova as the medial pivot knee kinematic. This medial pivot knee kinematic will also have an effect on the patellofemoral joint because as shown in these two papers, with more tibial internal rotation during flexion, this will translate the TTA anteriorly and medially and will relieve the patellar pressure during the knee flexion. So it is very important to remember that the soft tissue balance in a normal knee will have an effect on the knee kinematic and also on the patellofemoral joint. From history, we designed some implant to increase their long-term survivorship and release the stress at the implant bone interface. As here you see this implant design, which is a central pivot, will not restore a normal knee kinematic because normal knee have a medial pivot kinematic, and in this case, when one condyles move forward, the other one moves backward. So it was good for long-term survivorship, but not restoring our patient function, and then we can understand why they were not satisfied. Similarly, other design to improve flexion, like the PS design, these design translate both condyles posteriorly from 40 to 60 degree of flexion. So again, not replicating the normal femoral-tibial harmony in a normal knee. Some medial pivot design in their early phase were quite promising, but as you can see here, it was not well understood that the medial compartment should have some translation to a less extent than the lateral compartment. So in this study, the first evolution of a medial pivot knee had much less flexion than a PS design because the medial compartment was too constrained and did not allow limited translation on the medial compartment. Another key feature of implant design is their radius of curvature. We know that the normal knee is almost a single radius. So all the J-curve design femoral implant do not replicate the normal knee articular surfaces. In mid-flexion, it will create a zone of increased laxity in the MCL and LCL that will create some mid-flexion instability and some abnormal femoral tibial translation when people will try to raise from a chair or during stair climbing. Also, we know that the pivot point, the flexion axis of the femur, is very important. It will affect the strength of the quadricep muscle because it will create the lever arm with the patellar tendon. The early designs, as you can see here, the posterior condyles are way behind the align with the posterior of the tibial plateau. In a normal knee, the femoral condyle are in line with the tibial posterior rim, and this has a direct effect on the pivot point of the knee to create a nice contracture of the quadricep and maintain its strength. In the middle, you have a total knee design here, which is more of a single radius and more anatomical than this multi-radius implant. The benefits of a single radius implant was shown by different studies, and this one is very interesting, comparing the triathlon single radius design with the Duracon multi-radius design. This is a study by the Cleveland Clinic. After 4-year post-op, all the interesting outcome regarding pain, stability, flexion, stair climbing, walking were all improved in the single radius implant. Similar study done at the other side of the world in Perth, same implant, triathlon versus Duracon, larger number of patients, and very similar finding at 1 year and 2-year post-op. So there is a clear benefit of using implants that are nearer than the normal articular surfaces of a native knee. So we saw that the knee kinematics of a knee, native or prosthetic, depends on the articular surface geometry, on the ligament laxities, and then we should look at our surgical technique. How can we have a positive effect in the restoration of the normal knee kinematic during the operative time? From 1973, Michael Freeman proposed to use right angle cuts to perform a total knee arthroplasty. This was called the mechanical alignment technique. This is a systematic technique, one size fits all, where all human knee are implanted the same. Interestingly, we looked at a population of 4,800 patients waiting for a total knee replacement. We looked at 3D reconstruction of their lower limb CT scan. And the mean hip knee ankle angle was very near neutral, 0.1 degree, so similar to the mechanical alignment goal. But if we look more in detail, there was only 4% of the tibia where the articular surface was neutral at 0 degree, only 5% of the femur had the mechanical alignment of 0 degree, and only 0.1% with both at 0 degree. So mechanical alignment technique only replicates 0.1% of human anatomy. Here we can see the modifications linked with mechanical alignment technique. You see that both on the tibia and femur, we have a correction, a mean correction of about 3 degrees of the distal valgus of the femur and the proximal varus of the tibia, but the range is quite large. Okay, so let's see what we do during the normal mechanical alignment surgery to the joint space and gaps. First, you can see on this screen, when we apply the distal cutting jig on the distal femur, mainly the jig touched the medial condyle first because of the valgus alignment of the distal femur. So we resect about 10 millimeter medially and a bit less laterally, 5 to 7 millimeter. So we distalize the joint line on the lateral compartment. On the tibial side, if we use a stylus on the intact side on the varus knee in lateral, we resect 10 millimeter laterally and a bit less medially, often 5 to 7 millimeter. So for an implant thickness of 10 millimeter, we would like to create gaps medially and laterally of 20 millimeter. What happens if we addition the medial and lateral resections? In most cases, we create gaps that are too small. In this case, 15 millimeter medially and 17 laterally, with an objective that was 20 millimeters. In a more structured scientific study, we looked at a 3D reconstruction of 1,000 knee CT scans, and we looked at the gap that were created by the mechanical alignment. As you can see here, the results are very similar to our previous demonstration. We are reducing the medial and lateral gap in a varus knee by 3 millimeter medially and 2 millimeter laterally as a mean value. The effect of this gap reduction in the varus knee will increase the need for a medial release, and on the lateral side will distalize the joint line and overstuff the patellofemoral space. The solution to restore the normal gap and ligament balance would be either to recut the distal femur to increase the extension space, recut the tibia to increase the flexion and extension space, or to try to increase the gaps by ligamentous release. We know that recutting the distal femur has a detrimental effect on patient outcome because any elevation of the joint line from 3 millimeter and more will have negative effect on postoperative knee society score versus patient where the joint line is maintained. But more important is the balance between the medial and lateral compartment. This was taught by John Insall early on, and we all know that the gap balance is very important on patient function and satisfaction. It is also known that the medial stability of the compartment is very important. People with a tighter medial compartment had a shorter time up and go and higher patient satisfaction, and lateral laxity, like in the normal knee, was also correlated with a better patient satisfaction and higher forgotten joint score. So the more we replicate the native ligament laxity and balance, the more we will achieve higher patient satisfaction and function. In mechanical alignment, Let's have a look here in our study of 1000 CT scan at the extension space. Imbalances were present in 18% of the valgus knee and 7% of the varus knee, with a difference of 5 millimeter and above. These difference of 5 millimeter between medial and lateral compartment are very important, and very often we cannot correct these imbalances with surgical release. So these very high imbalances created by mechanical alignment technique explain why many patients experience instability after their total knee replacement. In flexion, we know that to create a rectangular space with the tibial resection and posterior condyle resection, we need to apply some external rotation to the femoral component with mechanical alignment. In our study, again, we showed that very frequent imbalances above 3 millimeter were present when using the transapical axis or the 3-degree external rotation as landmarks. And in our result, we showed that the 3-degree external rotation was slightly better than the transapical axis. The reason why the 3-degree external rotation was producing less imbalances is that transapical axis is 5-degree externally rotated according to the posterior condyle, which is more than the 3-degree systematic approach with the PC 3-degree technique. And we also know that the mean varus change on the tibial side with the mechanical alignment is 3-degree. So if we use the transapical axis, which is an anatomical landmark with a non-anatomical tibial cut of 0-degree, we are increasing instability in flexion. So with mechanical alignment technique, we deliberately modified knee anatomy, and over the years, we worked hard to solve our mistakes. Textbooks were created to try to help as defining what was the best technique to release ligament, but in fact, all these imbalances that we had to correct were created by us using a systematic one-size-fits-all surgical technique. So we were chasing our tail. If we look at the 3D effect of the mechanical alignment on the human anatomy, you can see here on the left knee, the joint line is completely reversed compared to the right knee, where you see the joint line is oblique internally versus with mechanical alignment, it is oblique externally. So we're changing the joint line orientation with this approach. So with mechanical alignment, total knee arthroplasty, we modify articular surfaces, the knee functional axis, ligament laxities, and also we should not be surprised that we're modifying knee kinematics. A number of studies evaluated patients after total knee arthroplasty in gait lab with sophisticated instrument and tool, and they all showed that a total knee replacement implanted with mechanical alignment do not reproduce a normal gait or knee kinematics. So what is the solution? To reproduce normal ligament laxities, normal knee biomechanics, I think we should return to the start, look at anatomical study to reproduce or preserve the native knee function and geometry. The solution that we are proposing is to use the kinematic alignment technique, which aim at reproducing the pre-arthritic knee anatomy and function. So what is a kinematic alignment technique? It is a true knee joint resurfacing. So when removing an amount of cartilage of bone, we want to replace it with the same thickness of implant. It is a personalized surgical technique where the objective is to reproduce the pre-arthritic knee anatomy and function. This is a video provided by Medacta illustrating very well what is the kinematic alignment technique. So we want to set our distal resection compensating for the cartilage loss and bone loss and resecting an equal amount of thickness on the medial and lateral side. Same for the posterior condyle, where a symmetric resection is performed. After we finish the femoral cuts with the chamfer cuts to fit the implant and replacing the distal condyle thickness resected and posterior condyle resected with the same amount of implant. This takes in account the saw blade curve and also on the worn side, the thicknesses of bone and cartilage that are lost. On the tibial side, very similar technique. We want to look at the worn surface, compensating for the cartilage and bone loss, resecting a similar thickness on the medial and lateral compartment, taking in account the tibial slope, and replacing both compartments with an implant that match the thickness resected. As you can see here, we maintain the native joint line orientation and will favor a more normal knee kinematic. So let's have a look at the bone resections in these diagrams with the kinematic alignment technique. On the femoral side, we want to resect an equal thickness of 10 millimeter laterally and 10 millimeter medially. And on the tibial side, similarly, 10 millimeter are resected on both compartments. If we are adding these resection on the femur and tibia, we create a space that match the implant thickness of 20 millimeter. So there is no reduction in the space that we are creating. If we compare these resection to our diagram with the mechanical alignment technique, you can see the difference. The joint orientation is maintained, and also medial and lateral gap equals the implant thickness. This is another illustration of the created spaces with the kinematic alignment technique. On radiograph, you can see the joint orientation. On the right knee, it is a kinematic alignment implantation where the joint line is maintained in comparison to the left knee where the joint line is reversed as we saw earlier. So what's happened with the femoral external rotation? With kinematic alignment technique, we do not add some rotation to the femoral implant. So we want to create a symmetric resection of the posterior condyle. So we will maintain the native femoral rotation. It's a resurfacing of the femoral bone. This will have an impact on the patellofemoral joint, as you can see in this bilateral case with kinematic alignment on the right side and mechanical alignment on the left side. The patellofemoral joint is more congruent on the kinematic alignment side, where we implanted the femur with 0-degree rotation compared to the mechanical side, where there was 3-degree rotation into the implant. Many people fear to leave the lower limb in some varus after a kinematic alignment technique. If we look at this patient where the right lower limb was implanted with mechanical alignment and the left lower limb with kinematic alignment technique, we see that the HK is very near neutral on both sides, and keep in mind that the mean HK of a normal population is around 0-degree. So in most cases of kinematic alignment technique, your final HK will be in the range of -1, 0 to +1 degree alignment. We should differentiate accuracy versus precision. For many years, with mechanical alignment, using tools that were not very precise, we had some surgical errors linked to poor clinical result and implant survivorship. As you can see on the left side, where on the target, we were shooting all around. With improved tools like robots or surgical navigation, we improve significantly the precision of mechanical alignment technique. Increasing this precision has no effect on patient outcome and satisfaction, so we improve precision but we were in fact not accurate. We were not targeting the right bullseye. Using a kinematic alignment technique with high precision tool, we have high precision, high accuracy, because we're shooting at the right goal, and we should expect to improve our patient function and satisfaction. With kinematic alignment technique, is there some limits? What is a normal knee anatomy? We know from experience on the hip side and knee side that there are some pathoanatomy, some hips and knee where the anatomy is linked with early disease and degeneration. In our group of 4,800 patients, if we look at these extreme anatomy, there was around 20% of distal femur above 5 degree and proximal tibia above 5 degree, leading to a HKA of more than 5 degree in 19% of the case and a HKA more than 10 degree in 3% of the cases. These extreme anatomy may not be compatible with modern knee replacement. So in 2011, I proposed to use the restricted kinematic alignment protocol. With this protocol, our goal is to maintain the postoperative hip knee ankle angle within margin of plus or minus 3 degree with a femoral and tibial cut of maximum orientation of 5 degree according to their long mechanical axes. I performed more than 1,000 total knee arthroplasty using this protocol since 2011, and we published some early results on this technique in different journals. The protocol to be used with restricted kinematic alignment is very simple. As you can see here, using that algorithm, in about 50% of the case, there would be no adjustment to be performed to the patient anatomy, and this will reproduce a true kinematic alignment technique in 50% of our patients. In another group of patients, we need to make some minor adjustment of about 1 degree, and this is corresponding to about 30% of our patients. In a smaller group of 20%, we need to make more significant corrections because these patients have unusual anatomies, and in most cases, they have a femur and tibia oriented in the same way, so both in varus or both in valgus. Since 2011, I'm performing all my total knee replacement with restricted kinematic alignment protocol, mainly using computer navigation or personalized instruments. And my experience is that using this protocol, I had to do very rare ligament release, only in cases where I need to make correction above 2 or 3 degrees. And it's also easier surgery. It solved many issues with some complex case, especially these severe valgus patient. If we compare the results of the restricted kinematic alignment protocol with mechanical alignment bone resection, the effect on the medial and lateral imbalances, you can see here we are maintaining the compartment balance within 0 to 2 millimeter in 92% of the RK cases versus only 68% of the MA. These results were confirmed by a study done in Australia where they randomized about 60 cases to MA or RKA, and they looked during surgery at the knee balance at 10 degree or the need to do recut when the unbalances were present. You see the significant difference between K and MA, where only 35% of the MA cases were balanced at 10 degree, and very high amount of MA cases needed bone recut or ligamentous release. So the take-home messages here is that restricted kinematic alignment technique keep HK in a safe range of plus or minus 3 degrees. It better maintain compartment gaps than MA. It reduces medial lateral imbalances. Moreover, it reduces the imbalances above 5 millimeter, which may not be correctable surgically. So RKA is a great alternative to MA to better reproduce patient anatomy, function, and ligament balance while keeping the lower limb alignment in a safe range. The result of our RKA technique in patient was assessed in a study where we compared 18 K total-knee patient with 18 MA total-knee patient using the same implant. We assessed their gait with the knee KG tool. Their results were compared to 170 LT controls where there was no knee pathology or implant. The results were clear. Our K patient had a similar gait pattern and knee kinematic compared to the group of LT patients. In the MA group, there was a significant difference for all parameters versus the LT group. And moreover, with MA, there was significantly more adduction or varus during gait than the K group. If we looked interestingly at another paper we published comparing two knee design implanted with MA, you see here the triathlon versus NextGen, and compare with normal knee patient, you see that both implants had a similar curve in adduction and abduction. But then if we compare this graph comparing the two knee design at the top with the graph at the bottom where it was the triathlon knee here and here, changing from MA to KA had a significant impact on knee kinematic, much more than the knee design impact. So our surgical technique is one of the key feature to improve our patient knee kinematic. This led to significant difference in clinical outcome for these patients, plus 13 point in the K group versus the MA group. This difference of 13 point is major. This is something that you cannot obtain by changing implant design. This benefit of kinematic alignment was confirmed in many studies, and as you can see here, 3 different meta-analyses concluding that K achieve either equal or superior clinical function than MA without increasing the adverse event or revision rate. This is another study where we assess the foregut joint perception in a group of 100K total knee after 40 months. Our mean foregut joint score was 77, which is one of the highest score published yet. And if you compare this great result, in the American population, the foregut joint score is around 67, including all comers with knee problems. And UK result are between 67 and 74, and total knee with MA 55 to 65. So changing our surgical technique to kinematic alignment had a dramatic effect on the foregut joint score results. So if we can improve our patient clinical result, we must make sure that the long-term survivorship of the implant is adequate. The first series, Achieving 10 Years, published by Stephen Howell, the pioneer of kinematic alignment, showed that he achieved 97.5% of survivorship with revision for any reason in 222K total knee, which is a great result. And in my experience, with more than 1,000 knee done since 2011, had no revision for aseptic loosening yet. I had 2 deep infections and 1 sizing error. If we look at a recent published study using a very high parametric tool to assess implant survivorship, using a randomized control trial and RSA evaluation to estimate implant survivorship in the long term. The group of Dunbar in Halifax showed that the K knee and MA knee did not present a difference in their migration after 2 years, and their migration was below the threshold for both groups. These results are reassuring and also very promising for the kinematic alignment technique. So after more than 40 years of mechanical alignment total knee arthroplasty, I am surprised it lasts so long. And recently, Dr. Rivière and I, founder of the Personalized Arthroplasty Society, published an editorial suggesting that it is now time to change. It is the end of the era of mechanical alignment technique. We think that we should propose a new way of performing hip and knee replacement, which is more personalized, trying to restore patient anatomy. If you're interested to read more about this topic, please visit the Personalized Arthroplasty Society website, where there is the textbook Personalized Hip and Knee Joint Replacement, available open access. Thank you very much for listening, and I hope to see you in the next video.